And Dr. DeCenzi is already on. I'd like to say good morning, but it's probably good afternoon in your time.
It's good night here. Can you hear me well?
Yes, and we'll have Dr. Block introduce you, Dr. DeCenzi.
Okay.
Okay, so several years ago, probably 5 years ago, we heard the 5-year data for low-dose tamoxifen, which was pretty exciting. But as you know, with ER-positive breast cancer, 5 years isn't a very long time. So now today, I'm very excited. We have Dr. Andrea DeCenzi, who can present the 10-year data. I heard him speak at San Antonio Breast Cancer Symposium, and he gave a great talk. He did graduate with first-class honors from the Medical School University of Pavia, and then he went on to specialize in his medical oncology at the University of Genoa. He is currently the director of the medicine department, as well as director of the Division of Medical Oncology at the Galleria Hospital in Genoa. Dr. Cenzi?
Thank you so much. It's really a pleasure to be invited at the Nebraska Society of Oncology. I wish I could be there with you, but anyway, it's really a pleasure for me. So this is another de-escalation study, and I wish it's always a pleasure to hear surgeons de-escalating, but we as medical oncologists should be more de-escalating than we are currently doing, especially in advanced disease. Anyway, I will present the 10-year data of the baby-TAM trial for TAM-01 in women with non-invasive breast cancer on behalf of my co-authors. So just a few slides of introduction. What are the key ingredients for a successful cancer prevention medicine? Is the fulfilling the ABC paradigm. So A, having effective and non-toxic agents. B, measurable biomarkers of individual response, which is probably the most difficult task. And third, or C, a precise identification of high-risk cohorts. I think I will show data that A and C can be satisfied by our approach, whereas we still have some work to do on the biomarker stuff. So as you well know, SERMs have been shown to decrease by 50% the incidence of breast cancer in at-risk women, including women with selected by the Gale model or the Tyrer-Cuzick model, or women with high-risk lesions. This is a meta-analysis conducted on 9 phase 3 double-blind placebo-controlled trials, showing definitely that there is a striking efficacy of selective estrogen receptor modulators in decreasing breast cancer. And likewise, aromatase inhibitors have been shown to decrease breast cancer in at-risk women. This is the MAPFLI study with exemestane, showing an even greater 65% reduction of breast cancer in women selected by the Gale model. And similarly, the anastrozole trial in the IBIS-2 show a significant 49% reduction of breast cancer in women selected with a Tyrer-Cuzick model, and also very interestingly, a carryover benefit 5 years or 7 years after treatment cessation. So despite this strong evidence of efficacy, the uptake of chemoprevention in the clinic has been very low. This is an old study which shows that the uptake of the potentially eligible women does not across 1%. And this is true both for tamoxifen and braloxifene. So there are a variety of reasons for this low uptake. We believe the most important of them is the concern of adverse events. There's also an argument that the no mortality effect has been demonstrated in phase 3 trial, but this is beyond the ability of phase 3 trial to show a mortality effect in this low risk population. Low risk compare, of course, to the clinically manifest disease. There is a desperate need for surrogate biomarkers which can illustrate the response short term, such as we have for cardiovascular medicine with LDL cholesterol or blood pressure. Some argue that the disease is still curable after diagnosis, which does not take into account, in my opinion, the burden of the impact of a diagnosis of breast cancer, both psychologically, clinically, and also financially. And finally, I think a very important reason for the low uptake is the poor commercial interest of these drugs, which are all generic, and because pharmaceutical companies tend to stay away from prevention for a number of reasons. So these are the ASCO guidelines for offering endocrine therapy for breast cancer risk reduction. The threshold for considering prevention has been elevated to 3% at 5 years, or 10%, or 5% at 10 years, with either the Gale model or the Tyrer-Cuzick model. Women with high-risk lesions, including atypical hyperplasia, ductal or lobular, or LCAS, have a much higher risk of developing invasive breast cancer, up to 10 times. And so these are another high-risk cohort where offering prevention is good clinical practice. The guidelines indicate that low-dose tamoxifen may be an alternative in women with non-invasive disease, as I will show. No endocrine therapy is advised in women 70 years old or older. And the recommended duration is 5 years, but 3 years may be considered based on the MAP3 trial and our TAM01 trial. So this is a couple of very important papers published last year by the FDA and the ASCO, illustrating the importance of the dose right in medical oncology, especially with targeted therapy. We have been drawn, for me, for instance, with the concept of the maximum tolerated dose based on preclinical models, but with the targeted agents, more is not necessarily better. But in fact, there is evidence that many drugs are registered at the too excessive dose, which can confer clinical and financial toxicity. And so this is especially true for prevention, where the therapeutic window is very narrow. And so we have several examples of registered drugs which have been then in the clinical practice used at an off-label indication, lowering the dose, like niraparib, ceritinib, dasatinib, ibrutinib, lenvatinib, pazopanib, some chemotherapeutic agents like cabazitaxel, immunocheckpoint inhibitors like nivolumab, and several endocrine agents, including tamoxifen, exemestane, abiraterone, and possibly enzalutamide. What we have done in the last 25 years now is investigating the minimal effective dose. In prevention, it is more important to search for the minimal effective dose rather than the maximum tolerated dose. However, we have translated the therapeutic dose in the prevention setting with tamoxifen, raloxifene, and AIs, and this is probably the biggest mistake and the biggest reason for the low uptake of chemoprevention. So this study dates 25 years ago, where we showed that a dose of 10 milligram on alternate days of tamoxifen was as effective or even more effective than the full dose of 20 milligram in decreasing total cholesterol. And there was also no difference on IGF-1. So this was the first evidence we provided in the clinic that lowering the dose does not lead to an inferior effect on the modulation of some pharmacodynamic biomarkers. We then move on with a randomized pre-surgical non-inferiority trial where we tested 5 milligram per day or 1 milligram per day versus 20 milligram per day in a window opportunity study of 4 weeks before surgery, looking at the change in Ki-67 as the primary endpoint. And this study showed that, as you can see, the reduction of Ki-67 with 5 milligram and even 1 milligram is non-inferior to 20 milligram per day. And this provided strong biological evidence that those reductions did not equate into an inferior effect on an important surrogate endpoint, such as Ki-67. So we then started a number of trials with baby-tam, which is 5 milligram per day for 3 years. This is the 007 trial in premenopausal women at high risk for breast cancer, where we were able to show that mammographic density was significantly reduced with baby-tam at 12 or 24 months, both alone or in combination with fenretinide, which is a retinoic acid derivative. And this is another biomarkers which is actively investigated currently as a potential surrogate endpoint for clinical trials and prevention. So we then started to use it in our clinic in a prospective study because the formulation of 5 milligram is not in the market. We have used 10 milligram on alternate days for prevention of recurrence in high-risk DCIS. This was conducted at the European Institute of Oncology in Milan, and the choice which was offered to the patients was no treatment after radiotherapy or low-dose tamoxifen. And this was based on patient preference. So it's not a clinical randomized trial, it's real medicine. And you see the majority of women opted for no treatment, but the data which show that in this high-risk population, low-dose tamoxifen was able to decrease by 57% the recurrence from a DCIS in a tertiary referral center, which tends to have a selection of high-risk individuals. So we then had no more excuse and had to do a phase 3 randomized trial. You can imagine it's not easy to conduct a study, such an expensive study, without commercial interest, because Tamoxifen is very cheap, at least in Europe, and so we had to work very hard to find sponsors for the study, which is TAM-01. Is a study in women aged 75 years old or younger with intraepithelial neoplasia, including ADH or LCIS, or ER positive or unknown DCIS. And the women were randomized to 5 milligrams of tamoxifen for 3 years, which is baby tam, or placebo. And the data we presented in San Antonio refer to 3 years of treatment plus at least 7 years of follow-up. The primary endpoint is the incidence of invasive breast cancer or DCIS. We recruited 500 participants from 14 centers in the country. Clinical visit and quality of life questionnaires were performed every 6 months for the first 3 years, and then annually with mammography and clinical visit or even telephone visit, and no more questionnaires were delivered. These are the centers in the countries. You see our booths, and most of the centers were in the north. And this is Genoa, close to the French border, which was the coordinating centers. And there were also a few centers in the south of Italy. The main subject and tumor characteristics were the following. The mean age was 54, 45% were premenopausal. The mean BMI was around 25, 20% had ADH, 10% had LCIS, 70% had DCIS. DCIS was included if it was ER positive or unknown. And this is the distribution of the positive. 2/3 were positive and 1/3 was unknown. And radiotherapy was delivered in around 60% of all DCISs because we de-escalated the CIS treatment in women with G1 or lack of necrosis or comediotype, and in older women, we don't give radiotherapy. It is important to underline that we are speaking here of surgically removed high-risk lesions. We know there are differences between Europe and the United States in this attitude because in your country, LCIS may not receive surgical removal if there is a consistency between mammography, imaging, and pathology. In this cohort, all the women had received a surgical resection regardless of the histology. So what we had shown in 2018 in San Antonio was that there was a 52% reduction of breast cancer or DCIS with baby tam, which was statistically significant. And there was a 76% significant reduction of contralateral breast cancer with baby tam. There was no difference in serious adverse events, and no difference, perhaps more importantly, in patient-reported outcomes evaluated by the breast cancer prevention questionnaires on quality of life, except for less than an extra hot flash per day on baby tam. Today, I will not show any further follow-up data on patient-reported outcomes because, as I mentioned, we stopped to deliver questionnaires after the 3-year intervention period. And these are the findings on hot flashes in the initial evaluation at 5 years. As you can see, there is a slight increase of less than an extra hot flash per day on baby time. No difference in the severity of hot flashes between the two arms. No difference in vaginal dryness or pain during intercourse between the two arms, and no difference in musculoskeletal side effects or arthralgias between the two arms. As a reflection of this good tolerance, the treatment adherence was not different between tamoxifen and placebo, but in fact there was a slight trend to a better adherence with baby tam. And this is in striking difference with the full dose. You see, for instance, the IBIS-1 data where there is a clear 10% absolute difference in treatment adherence between 20 milligrams of tamoxifen and placebo. So what happened after San Antonio 2018? ASCO and US Preventive Services Task Force guidelines included baby tam for preventive therapy in high-risk lesions. NCCN recommends baby tam after DCIS if a patient is symptomatic or unable to take the full dose. And interestingly, baby tam has become the most popular treatment in high-risk lesion in the US, with lower discontinuation rate versus 5 milligram or 20 milligram tamoxifen or raloxifene or AIs. This is, for instance, a recent paper from the Dana-Farber Brigham's Cancer Center by Tari King and Judy Garber's group, where they showed that in premenopausal women, now baby tam is the most popular options in women with high-risk lesions, and also there is an important fraction of postmenopausal women receiving baby tam. And more importantly, the discontinuation rate at 1 year was lowest, much lower, with low dose tamoxifen compared to full dose tamoxifen or raloxifene or an aromatase inhibitor. So now going to the 10-year data, we asked the question, is there a carryover effect as with 20 milligrams per day for 5 years? So we did an annual follow-up with mammography and clinical visit or telephone contact. The primary endpoint was invasive breast cancer, DCIS. Breast events were 66 and were all centrally adjudicated. The analysis is based on a median of 9.7 years of follow-up. So this is the main finding. There was a significant 42% reduction of any recurrence with baby tam, and with a nice carryover effect. So even 7 years after treatment cessation, there is still a significant benefit of baby tam. In terms of subgroup analysis, you know that the study was not so large, so the study was not powered to look at subgroup effects. This is very important to remind. There was a benefit across all subgroups. On ipsilateral breast events, there was a trend to a reduction, which was not statistically significant because of lack of power. But there were still a significant 74% reduction of contralateral breast cancer with baby tam. This is the forest plot for the subgroup analysis, which shows that there was a benefit across all patient subgroups. And in particular, there was a significant reduction of recurrence in postmenopausal women, in women with low estradiol level at baseline, in women who were obese, which is quite striking, in never smokers, in women who underwent a mastectomy, and in women who had a DCIS at baseline. And this is, in fact, the curve of DCIS. We, as I remind you, was representing 70% of the overall cohort, and there is a 50% statistically significant reduction of recurrence in women who had a DCIS. There was no difference in terms of tumor characteristics between the two arms. The majority of recurrences, as you would expect, were invasive and ipsilateral, had T1 tumors, node negative, and there was no difference on the molecular phenotype, although it is interesting to note that the proportion of the HER2 positive disease was quite high. And finally, there was no difference in terms of Ki-67 between the two arms. Serious adverse events were not different at 10 years between the two arms. There were just one case of endometrial cancer with stage 1 in the baby Tam arm. No difference on deep vein thrombosis or pulmonary emboli. No difference on other neoplasms, nor was there on coronary heart disease, bone fractures, and other serious adverse events. Cataract and endometrial polyps, which are not serious but are two important adverse events of tamoxifen, were not significantly different between the two arms. Finally, death from breast cancer occurred only in 3 patients out of 500, and death from other causes were not different between the two arms. It is important to note that based on the NSABP1 trial, we would predict 5 cases of endometrial cancer with 20 milligram and 3.5 cases of DVT or PE with 20 milligram. So what are the limitations of our trial? Certainly, the study is not large, and so there was a limited power for interactions and subgroup analysis. Some people, for instance, our regulatory agency in Italy, claims that there is no vis-a-vis comparison with 20 milligram, which I think is a stupid argument, looking at the acceptance rate of full dose tamoxifen in high-risk lesions, and also because a non-inferiority trial would be poorly accepted and very extremely expensive to conduct. There is also the problem of the lack of 5 milligram tablet on the market, but we have shown that 10 milligram on alternate days is a reasonable choice due to the long half-life of tamoxifen. What are the implications of our data? Certainly, a reduction of breast cancer in high-risk lesions we have provided evidence for this, and possibly a new standard of care also in DCIS. We believe that the effect on contralateral breast cancer reopens the door for prevention in high-risk unaffected women, including women with dense breast or women with a high risk based on family history and other reproductive characteristics. What I see in my clinical practice is a huge number of women all over the world who are consulting me, asking for a dose reduction in the adjuvant setting because they don't tolerate the 20 milligram dose. And I think it's an option that is better than anything, lowering the dose in intolerant women. One important application, which I think is fascinating, is that with the use of baby tam, we can increase mammographic sensitivity in the screening setting. And there is some evidence from the Swedish group that the use of baby tam can reduce interval cancers in premenopausal women with dense breast, which we know is the worst side effect of screening. There is also some data in the United States that baby tam can reduce the risk of breast cancer in young women after chest radiotherapy who have, mainly for lymphoma, who have a risk of breast cancer which is comparable to the BRCA1 and 2 carriers. And finally, a research implication could be the risk reduction in moderate penetrance genes, such as the PALB2, CHEK2, or ATM carriers. And this is the Swedish data I was alluding to, where the group from Karolinska in Stockholm has shown that a 20% reduction of mammographic density with baby tam can lead to a 24% reduction of interval cancers in this high-risk cohort. So in conclusion, our findings indicate that baby tam 5 milligram per day for 3 years lower recurrence from non-invasive breast cancer after 10 years with the carryover effect and without adverse event excess. The benefit was seen across all subgroups, although with limited power. The low risk of death, only 0.6% at 10 years, strengthened treatment de-escalation in DCIS. And tamoxifen is one more example of missed optimal dose for targeted agents. I want to acknowledge the participation of the women and their families in the trial. We thank our hospital as well as the Ministry of Health and the 2 charities, the Italian Association of Cancer Research and the Italian League Against Cancer, for sponsoring the trial. Our sponsor have allowed to do an academic no-profit trial aimed to attain a safe, equitable, and affordable medicine. In Italy, the cost of 1 month of tamoxifen is $2-3. And we encourage young investigators not to miss the unique beauty of academic clinical research, despite the threats of devastating bureaucracy. But we believe our scientific agenda cannot only be dictated by big pharma. Thank you very much for your attention.
Thank you so much, Dr. DeCensi. Do we have any questions from the audience? And if for those of us joining virtually, please go ahead and write those in the chat box. Oh, yeah, Dr. Block.
Graph, it looked like premenopausal.
Can you speak to the microphone, please? Because I cannot hear you very well.
Is that better?
Yes, much better. Thank you.
So on your graph, it looked like the premenopausal women didn't get benefit. And I wonder in that group, especially, would you start with 20 milligrams and only consider the lower dose if you needed to de-escalate? I actually find the majority of my premenopausal patients tolerated, the 20 milligram dose pretty well, but just wonder what your approach would be with that group.
So I don't agree that we don't see a benefit. We don't see a significant benefit simply because of a power issue of our study, but the trend is beneficial also in premenopausal women. But I agree with you, the effect was not statistically significant. But again, I want to underline that our study is not powered to look at subgroup effects. So this is one point. The other is, yes, I think that there is a potentially biological explanation for this different effect, which is that in premenopausal women, estradiol increases with tamoxifen, and so the increase might not be sufficiently overcome by a lower dose. That's a potential explanation. So your idea of starting with a full dose and then de-escalate in case of adverse events is absolutely a reasonable option. As I say, I have a biased point of view because I receive consultation only from women who don't want or do not tolerate the full dose. So it's not that uncommon, but I agree with you. Is if the full dose is tolerated, there is more data with the full dose, and although the increase in estradiol can be really substantial with the full dose, we see a lower increase in estradiol with the low dose. But certainly your approach is more than reasonable.
Any other questions for Dr. DeCensi? Oh, sorry, there's one in the chat box. All right, from the chat box, do you see baby tan being used in treatment of invasive cancer? And if longer time, such as 10 years on low dose, would be better than 3 years, do we have patients? We do have patients who refuse tamoxifen because of the concerns for endometrial cancer.
So if I understand well the question, the duration of treatment is an important issue. And with this safety data that we have provided, I agree that the optimal duration remains an open question that our study has not addressed, because now that we have a reassurance about the safety and the tolerability of the low dose, one could envision to prolong the duration of treatment to, say, 5 years or more, or even think of an intermittent administration with cycles on and off. So I think we cannot answer the question, but in the clinical practice in invasive breast cancer, the women who want to stop any treatment, and we know that up to 40% in the adjuvant setting do interrupt the treatment because of side effects. I think that prolonging with low dose tamoxifen is a reasonable option in invasive breast cancer.
Do we have any other questions from our audience? All right. Well, seeing none, thank you so much, Dr. DeCensi. We really appreciate you joining us today.
Thank you so much. It was a pleasure to be here
All
with
right.
you today. Thank you.